right, let's go ahead and get started here. Let me take attendance. No Trey. No Trey today. All right. Good morning, Brianna. Welcome. Sophie said you're having issues with your computer. What I'm doing is I'm recording the meeting, so if if something goes wrong there with your connection or your computer, then maybe later you can watch it. I'll post it on um, our YouTube page and put it in Canvas as well for you
Thank
guys. Um, all right, so let's get started. So what did I want to start with? All right, so hopefully everybody got the email last evening with the assignments for chapter 12. They're going to be due Monday, 11:59 p.m. Homework and the pretest, and then the quiz. The quiz that I put out is 15 questions long. Open resource for the quiz, um, but you get one shot at it. Okay, so just take your time, get everything right. Okay, use your books, use your notes that you've taken, whatever else. All right, for chapter 12. So open resource, quiz. Obviously, homework is always open resource, and they're both due at 11:59 p.m. on Monday. It shouldn't take very long. It's not a long chapter. Um, but I think the homework is going to be important in this one because it gives us there's a lot of questions kind of like are scenario kind of based, and they'll give you little scenarios that will make you think about what you need to do first. Like it'll ask a patient, or it'll say like, all right, you've come across a patient, and it's a boy that looks like a teenager, and he's running towards you, and you can see he's clearly upset, and he's bleeding profusely from his leg. And it'll be like, what do you do first? Do you open his airway? Do you take his vital signs? Do you control the bleeding, or whatever? And obviously, in that case, it would be control the bleeding. So um, it'll start getting us into some of these critical thinking modes about how we can approach our patients and what's going on. So take your time with the homework, think through things. Obviously, you can do the homework as many times as you want to get things right and to correct the issues there. So get 100 on that as well. Again, 11:59 p.m. for pretest homework and that quiz. Um, there. How's everybody's understanding of the primary assessment? Do you guys feel good about it? Do you have questions? Are you unsure of like what the deal is? What do you guys think? I'll get some feedback from you here on how you're feeling. Brianna, you're good. Dylan, you feel good about it. Sophie, you're good. Cool. All right. So I think it's pretty easy to understand. You're good at Haley. Excellent. I think it's pretty easy to understand. It's where we start our detective work and gathering information, and um, obviously the goal is to figure out our patient's priority, how urgently we need to move, and find any life threats and correct those right away there. So I think it's pretty straightforward, but when you start applying it to situational situations, um, it's important that we start that process, that critical thinking process. Um, Let me ask you guys this a question, because these are going to come up. These type of things are going to come up. All right. Um, let's say you've got a patient. All right. That is unconscious with kind of snoring respirations, right? So they're unconscious, and you come up, and their breaths are they're the respirations are snoring. So you hear some sounds and they're kind of slow. What would you do first? Right. So we've got snoring respirations and they're kind of slow and unconscious. Um, would you give them a breath first? Would you listen to their lung sounds first? Would you open the airway first? Or would you give them oxygen first? What do you guys think? You can type it in the chat or unmute your mic, whatever. Dylan, open the airway. Okay. Airway, Michelle. Airway, Sophie. Brianna, same. Haley, same. Good. That's exactly what we need to do. All right. Whenever there's a question, like obviously there's things we need to do for this guy, right? If there are slow respirations, we need to give breaths. But before we do any breaths, we have to open the airway. So that's a very good start from everybody in saying that. Okay, because we've got to remember like the simple steps before we give anybody, especially an unconscious person. Well, if we're breathing for a conscious person, they have their airway open, right? Like you guys did for me. When you were doing the bag valve mask for me, like my airway was already open. You didn't have to open it. But if they're unconscious, we have to open the airway first. So you're going to run across questions like that about which order to do things. And some of the things like you're definitely going to do with this patient, like give breaths or give oxygen, but can't forget what like order things kind of happen in. So that's good start on that stuff from you guys. I like that. Okay, what we're going to do today is I'm going to go through the chapter 13 today, and we'll get through that today. It's vital signs, so we'll talk about vital signs and gathering them and what it means for us and how to do it and all that kind of stuff. We've done some of the skills in class, and we were going to be practicing, but when we get back in person, we'll practice this stuff. So let me share my screen and we'll get started here with that. All right. Everybody good? Everybody see the screen there? Cool. Yeah, just give me the thumbs up there if you can. All right. There it is. Sorry, I'm just arranging things on my screen so I can see everything well. Haley, you're good. Cool. All right. So let's talk about vital signs today. Why they're important, how we do it, all that jazz. All right. Vital signs. So these are outward signs. And remember, a sign is something that is observable, something that is measurable, right? So like skin condition would be a sign because it's observable. Vital signs are a sign because they're measurable. A symptom is something that we can't measure, but it's usually what the patient's feeling and what they tell us. So a sign is something that's observable or measurable, and vital signs are signs of what's going on inside the body. We can identify like important conditions or trends in the patient's condition. Like might be able to see if they're getting worse based on their vital signs or getting better based on their vital signs. So they're important to see and keep an eye on there. And we get them on basically every single patient, every single one, even the ones that will call us and like, I'm not even sure if I needed to call you. And well, I think I've changed my mind. I don't think I need to go to the hospital. And if we get a refusal for them, if we get them to sign the refusal form, we'll still take a set of vitals on even those patients. The patients we might not be able to get a vital signs on, we might be too busy doing stuff in the back of the ambulance. Like um, maybe you're just by yourself in the back of the ambulance, and it's you and a driver, and your patient is in back and they're unconscious, and you have to bag valve them, BVM them. So if that's the case, you don't have time, you don't have the extra hands to do it. So there are some cases where you may be too busy, we're doing other things, there's not enough crew there, right? If it's only you in the back and you need to do something else like breathe for them, you might not be able to get them, and that's okay. That's okay. We'd like to have them, but sometimes we can't get it. So if you can, yes, get them. If you can't because you're too busy doing other things, that's okay. So like I said, you may not get them. So it depends on how severe the patient is, your priorities in treatment, how many EMTs you have. So you might not be able to get them. All right, so what are the vital signs that we're going to get? We're going to get the pulse, the respirations, skin condition. Right? This is skin condition, and for that, we're going to look at their color, we're going to feel their temperature, and look at the condition. Like, is it dry? Is it wet or moist? Are there hives all over it? Things like that for the skin. We'll look at pupils, and we'll take blood pressure, and then I'm going to add one more in here. We're gonna get their pulse ox as well. We want to see the percentage of oxygen that's in their blood, and I mean, we're going to learn how to do everything manually, but a lot of these things can be done with machines. And so, like when you throw a pulse ox on, when you're doing your vital signs, you're also getting your pulse rate as well. And in real life, we can put that on, and then we'll have the pulse ox number and the pulse, within a minute or so. The pulse is usually accurate very quickly. The pulse oximeter, that number can usually take a minute or so. So it can be kind of a quick way to get these things using the machines there. But obviously, we can't use the machines at all times. So obviously, we need to know how to do this manually. All right. So when we take vital signs, our first set of vital signs that we're going to get is their baseline vitals. All right. This is the first one, and we call it the baseline because we're going to base any subsequent sets of vital signs off of this. So we'll take the first set, and then hopefully we'll at least get to take one more set. Your goal, you should be able to take vital signs twice on a patient in a call, at the very least. So maybe once when you get there, and maybe once more before you get to the hospital, to see if anything's changing, right? We want to see if there's anything's changing. In more serious patients, like somebody that's unconscious, or they're bleeding out, they're in shock, something like that, you probably want to get vitals like every 2 minutes. Okay, and that way we'll talk about trending things, right? So we can see if a blood pressure, well, 10 minutes ago your blood pressure was here, and then it moved down here 8 minutes ago, and 6 minutes ago it was a little further down. So if we get trends, we can see them if we do repeat vital signs. If we repeat doing vital signs, we can see things moving in directions, whether it's good or bad. So our first set is called the baseline vitals, and our second set will be just repeat vital signs there. And again, this information is going to let us know what the body's doing. Is it kicking in to compensate more for whatever's going on? Is it starting to fail to compensate? We can see these things based on their vital signs, right? Like, as we all know, if we have somebody that's got trouble breathing, right, we expect a couple of things to happen with their vital signs. One is that their heart rate's going to go up for a while, and their respiratory rate and depth and all that is going to go up as well. So if we're trending them and then we start seeing that heart rate drop, that could be a result of two things. Either our interventions are working and the body's not compensating as much because like maybe we're giving them oxygen or breathing for them and things are settling back down towards normal because of what we're doing. Or maybe that's a sign that they're decompensating, like they can't compensate any longer and they're heading down into shock, right? There'll be other things to show us which one is which. Like for example, skin condition. If we're breathing for them and all that and everything's good, then their skin will look good, right? It'll be full of their color and things like that. But if it's looking bad and those heart rate and breathing rates are going down and the skin looks bad, what's wrong? There's a big spider in the TV room. Okay. Where is it?
On the TV rug.
On the rug? Right. Okay. Dad's got to go kill a spider. Give me 1 minute. A minute.
Let me come show you what I made.
They're okay. They won't hurt you or anything. They just look funky. I got it for you, babe. Champion spider killer. Thank you. Thank you very much, Dylan. I appreciate it. Dad saves the day once again. All right. That spider's vital signs are 0. There's nothing there. Nothing to trend. All right. Did we lose Michelle? We lost Michelle. Okay. Oh no, there you are. Okay, sorry. There she is. All right. Let's see. What was I talking about? All right, vital signs. All right, so baseline is the first set we'll get, and then hopefully we can get at least one more set on like a stable patient. If they're unstable, right? If this is a critical patient, or they're unstable because of what their vital signs are showing you, then we're going to try to take them like every 2 minutes or so. All right. That seems, it's basically like you take a set of vital signs, you wait about a minute, and then you start doing it again. There again, that's to get the trend, right? If you were to graph things, you can see how well or poorly things are moving there for them. All right, so we've talked about the pulse a whole bunch and we learned how to take it. So we're just going to kind of cruise through this part here a little bit. We know what the pulse is. It's that pressure wave moving down through our arteries after the heart has squeezed the blood out. And it says palpable pressure. Palpable means to be able to feel it, right? If we palpate something, it means we touch it, we feel it. So we palpate a pulse by touching and feeling the pulse. Yes, ma'am.
My mom has that on a shelf, and when I woke up, and the other day my elf on the shelf was over there. But now today, my elf on the shelf is over there.
Unbelievable! I love it. Hey, listen, Dad's a little busy. Listen. I need you. I know you want to hang out, and I want to hear all about Elf on the Shelf, but I have to do this. Okay. So I'll see you in a little bit.
Okay. On the shelf is
I will see you in a little bit.
Okay.
See you later.
See you
later. Sorry. Thank you for your patience with this. It's not easy for anybody. I appreciate it though. All right. So I was saying palpable. Palpate means to touch, to feel. Okay. So we're going to use that a lot when we get to our secondary assessment, and we're actually really touching people, especially trauma patients. All right. All right, we know how to take one. We can place our fingertips over top of the artery where it's near the surface and where it crosses over a bone or a harder structure there. It's not necessarily bone where we're pressing it into, but it's always be next to a harder structure for protection there. When we're taking it, we want to get the pulse rate, which is the number of beats per minute. And we know that that the normal rate for an adult is between 60 and 100 beats per minute, right? That's the resting rate. So all of us right now, except for me, maybe I'm still coming down from the excitement of killing that spider. So maybe I'm a little bit higher than normal right now. Maybe I'm a little tachycardic from the adventure I was just on and killing a spider. But that's normal. Context matters, right? So 60 to 100 is normal for an adult, and that's what we're looking for them to be. Anything above 100 is called tachycardia, and that's 100 or over there. And bradycardia is anything that's below 60 beats per minute, okay? So those are abnormal findings, anything above 100, anything below 60. But again, context always matters. So maybe your patient's pretty anxious about you coming to their house and their medical problem or whatever it was. And just being anxious can elevate things like your heart rate and your blood pressure and your respiratory rate a little bit. And so context matters. So if we find somebody that's particularly anxious about us being there and the whole situation, and they're at like 112, 110, 120, something like that, then it might be okay. It might just be fine. And maybe we'll see it trend down as they get more comfortable with what's happening there with us. So above 120 or below, above 120 or below 50 is kind of considered serious, but there are kind of exceptions to that. Again, context matters. If we have some athletes in the class, right? We got some of you guys that play sports and y'all are in good shape and things like that. So if you get a patient and their heartbeat is like 50 beats per minute or even in the high 40s, if they're a real athlete, that's normal. Like their heart is in such good shape, lungs in such good shape that actually their resting heart rate is lower. So that might be normal for them to be, 48 beats per minute. That might be totally normal for somebody that's a real athlete that's in shape there. And so again, context always matters. So we got to keep that in mind. And again, like I said, somebody's heart rate may be up because of an emergency. So 100, 140, something that may not be all that unusual. And again, we'll probably see the trend, see that heart rate go down. I'll tell you a quick story. When I was still in EMT class, actually. I was riding with this guy, Ari. And you guys ever like meet somebody and just like right off the bat, like there's just something that you don't get along. You're kind of head butting. Maybe you're not on the same wavelength or something like that. Ari was dealing with this patient, and she and Ari were not getting along for whatever reason. I don't even understand why, really. But I was at the point in the EMT class where I wanted to practice my questioning of the patient, asking about their history and all that kind of things. And so he said, hey, do you want to try? And I said, yes. And this patient happened to be on a pulse oximeter, which shows the patient's pulse rate, right? And so talking to Ari, she was at like 110, 114, something like that, around there. But then I started talking to her, and it's just nice and easy conversation, just trying to be calm and everything else. And after a couple of minutes of talking with her, you could see on the pulse oximeter, her pulse rate slowly coming down as she relaxed and talking to me versus talking to Ari. So It's not unusual, again, for a pulse to be elevated when somebody's stressed during an emergency situation, but you can put them on like the pulse ox and you can see it. And as they're calming down, maybe if they're like, you know what, she's an awesome EMT and like I'm in good hands here. Like as soon as they start to trust in us and things like that and believe that we can help them in this difficult moment, then maybe you're going to see that pulse rate start trending down there. So again, context always matters. So let's know, ba, 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 ba. Let's know this normal rate between 60 and 100. You have to know those numbers, and we have to know these numbers. Tachycardia is above 100, bradycardia is below 60. Got to know those numbers as well. All right. We just talked about what normal situations might account for it. Maybe I'm exercising, maybe I ran around the building, maybe it's an emergency situation and I'm getting a fight or flight response that's kicking in because I'm all worried about the situation and things like that. And that's going to boost my heart rate. And that may be a normal reaction. So again, context kind of matters with all that. Now, when we're taking the pulse, not only are we getting the rates, we're going to get the quality. And we talked about that a little bit yesterday or the other day with our primary assessment. And so what we want is the rhythm. Is it regular or irregular? Now, you know, if you feel your heart rate and you kind of get what the rhythm is, right? If you're taking your pulse and you get what the rhythm is, like you can predict when the next beat is coming. Sometimes there's a little bit of irregularity and you can actually predict when it's going to be irregular. These kind of heart rates, if you take like a paramedic class or you get into nursing or something like that, we basically have three things when it comes to regularity. There's regular heart rates, there's regular heart rhythms, there's regularly irregular heart rhythms, and then there's irregular heart rhythms. So right now, hopefully everybody's got a regular heart rhythm, right? Where we know it's boom, 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 boom. We can easily predict when it comes, when it's coming. And then there's regularly irregular heart rates where we can predict when that skipped beat or that extra beat is going to come in. And maybe after every second regular heartbeat, we have an early beat. So it would be like bum, 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 bum. And they're just in that kind of rhythm like that. That's called regularly irregular because we're having that irregular early beat, but it's after every second heartbeat. So we can predict when that irregular beat's coming. And then there's irregular. And this is where we're not able to predict when that next beat is coming. You'll have patients in atrial fibrillation with that. And with atrial fibrillation, your heart rate can be anywhere between, like I've seen in people be in very slow, but generally it's a faster rhythm. So you're up around 80 to, I've seen, people will have stretches, short stretches of like 3 beats when if you put it out over a minute, it would be like they're at like 300 beats per minute, but it only lasts for like 3 beats. So it'd be like bump, bump, bump. And then maybe there's a long break and then it's bump, 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 all over the place. You can't even tell when it is. So we want to look for the regularity in the rhythm. Okay. So first thing, obviously, is counting the pulse, but we want to make sure we figure out if it's regular or not, regular or irregular. You don't have to worry about regularly irregular or whatever. We just want to know regular versus irregular when we're talking about the quality. All right, and then the other factor when we're talking about quality is the force. Is it strong or is it weak? That's all that means. Pulses normally are strong. We can feel them nicely and easily. The term used in medicine when a pulse is weak, it's called thready. So if you have your patient has a thready pulse, it feels weak. It's not very strong. It's not full of its normal force there. So it feels weak, thin. That's called thready. So we want to look for in the quality, we're looking for the regularity and the strength of it, just like we talked about in the primary assessment. All right, so the most common pulse location that we're going to do, 99% of the time, we're doing this one, the radial pulse, 99% of the time, right? It'll be rare that we use other ones. We use the other ones mostly for like traumatic situations where people are injured. For example, let's say your patient was at like a climbing gym, okay, and they fell and they dislocated their elbow, right? It's all out of whack there. For that patient, like I would, well, let's see. Let's change that. Let's say they dislocated their knee, okay? Now, when I get there, I'm going to take the pulse on the patient at the radial pulse, but when I'm checking the injury, I'm going to check a pulse past the injury. So if they dislocated their knee, I'm going to check the peripheral pulses on their foot to make sure that the blood is getting all the way down there. Okay, so we will use other pulse locations, but the most common one is the radial pulse. We're going to use this in everybody that's 1 year old or older. That's the one at the wrist, obviously. It says first 3 fingers here, 2 fingers works fine. Obviously, never use your thumb. There's a small artery in here, and if we push down just right, you can feel the pulse in your own thumb. So if you're kind of taking the pulse wrong on the patient and your thumb's more on the bone, maybe you feel your pulse and you're counting that versus the patient's. So never use your thumb, always use 2 or I guess 3 fingers there. There's some dude taking another dude's pulse. All right, how do we take our more common pulse locations? The brachial pulse, we're going to use this for kiddos that are infants, so 1 year or less, right? That's an infant, 1 year or less. We'll use the brachial pulse just because it's harder to get an infant's little tiny artery right there, right? It's harder to feel that. The artery's bigger here, right, at the brachial location than it is here. And so it's easier for us to assess this one in the brachial pulse. There's a little cute kiddo getting her pulse checked there. She's looking at her parent. I guess that's her mom, like, what is happening? She's not happy about this. I bet you moments later that child was crying. All right, then we also have the carotid pulse, which is in the neck. It's on either side of the trachea right here. So it's bilaterally located on the neck on either side of the trachea. Quick point about taking the carotid, don't do both sides at the same time. Because if you're pressing into that artery there, we are obstructing blood flow for a minute while we're doing that. And if you press on both of these at the same time, guess what isn't getting as much oxygen as it normally would be? Your brain. All right. So just one at a time, right? Just one at a time. You don't want to knock somebody out because you're checking their pulse too hard on their neck, right? That probably wouldn't go over too well. So just one at a time if you're doing the carotid. All right, so when we're assessing the pulse, we learned about this. We count for 30 seconds and then multiply by 2. It's as simple as that. If we have a very fast rate or it's a very slow rate or the or the regularity is all over the place, then you may have to count for a full minute. Because sometimes if somebody's in fast atrial fibrillation, it's really hard to count their pulse because it's just so all over the place. So you may have to do it for a full 60 seconds there. But normally it's just 30 seconds multiplied by 2. That's how we do it manually. All right. Now, I think we all know that. Now, respirations, we know how to do this as well. Now, remember, when we talked about respirations at first, I said, hey, the definition for respirations is the gas exchange. and ventilation is breathing in and out. But later on, when we learn vital signs, it'll might be confusing for you, because when we get to vital signs and we say respirations, it means the breathing, it means the ventilation. So when we say respirations, count the respirations, we know that we're just talking about counting how many breaths they take there. We're going to look at rate and quality for this as well. The respiration rate is the number of breaths one person takes in a minute. And a breath is considered an in and an out, right? In and an out. So you only have to count it once, but that's a full cycle for breathing, in and out. So it's easy just to, we're not going to count that as two things. If somebody breathes, we're not going to count, okay, that's an inhale is one and an exhale is two. We're not doing that. We're just watching them. So an inhale and an exhale together is one breath. So we're going to classify it. Is it fast breathing? Is it normal, or is it slow? The normal rate for an adult at rest is 12 to 20. Again, context matters. We need to know this number. So we can know when it's abnormal. I think that makes sense, right? Age, sex, physical conditioning, emotional state, right? All of these things affect breathing. For example, a newborn should be breathing about 30 to 40 times per minute, right? If you had that rate on an adult, like, holy moly, we're in trouble, right? That is way too fast for an adult. That's perfect for a newborn, right? That's perfect for a newborn. For like the first week, something like that, they're breathing incredibly fast, and then it starts to slow down. One thing to note about kids and vital signs, they're always faster. The younger they are, they're always faster. So heart rate is up, respiratory rate is up for kiddos. And as they age, it comes down. You guys are just at the age where you're maybe by 18 or so, like it might be right now for you guys. It might be right around 18 or so, but right about now is when you start having those regular kind of adult vital signs. Your bodies have gotten to the point where they're adult bodies. And so your vital signs should be stabilizing right in that adult range. So your heart rate might be a little bit faster. So maybe for somebody that's 16 or 17, maybe your heart rate, the normal for you is like 65 to like 110, something like that. So that'd be normal. So physical conditioning. Say you come into somebody's house and she's 400 pounds and is a smoker, and just like getting off of the couch is a physical it's a tough thing for them to do, and so the heart rate skyrockets, the breathing rate skyrockets, all that kind of stuff. So emotional state, again, if they're really upset, if they're angry, if they're really anxious, things like that, then that can skew our vital signs too. So again, it's like so much of this is context. All right, so much of this is context. So any rates above 24 and anything below 8 is going to be considered serious. Now, if we have to start thinking about probably oxygen at these points, on the upper end for the breathing rates, if your patient is at rest and they're at 24 times a minute, we're probably going to have to think about oxygen. And we're going to have to start considering breathing for them. One of the things that we can do for a fast breathing patient is give them a BVM with oxygen, and it'll slow their respiratory rate down to a more normal range. So anything above 24, we're going to start saying that's rapid. Anything below 8, we're going to say that is slow. All right, for quality for respirations, we have to know a few things. There's normal, and what should normal be? It should be silent, and it should be easy. Their work of breathing should be easy, so it should be silent for that. There's shallow, So very shallow breaths, right? They're not full deep breaths. They're only breathing in for a little bit there. There's labored. This is when somebody's working hard to breathe, when somebody's noticeably working to breathe. And then there's noisy. All right. So we have normal, shallow, labored, and noisy. Those are our 4 qualities that we're going to be talking about when it comes to somebody's respiration. So let's say we had a patient that's trouble breathing. We can say that, let's say that they were at, let's say it's noisy and they're working hard and it's kind of fast. So let's say you're like, all right, what's their respirations? And I would say, all right, they're 24 labored and noisy, or 30 shallow and noisy and labored, right? It could be shallow, labored, and noisy, right? It can be all 3 of those things there. It's either normal or it can be any one of those 3 things or any combination of those 3 things there, the shallow, labored, or noisy. All right, so we're going to count the respirations after we do the pulse rate. And remember, we learned that little trick, right? It's 30 seconds and count by 2, but we're not going to tell the patients we're counting their respirations. As soon as a person is aware that somebody else is focused on their breathing, they're going to change their breathing and their rate. You know, we did the little trick where if we're checking a patient's pulse, we kind of put it against their chest and we can see or feel that chest rise and fall there, or you know, so we'll take the pulse, we do the 30 seconds with that, and then we just kind of do the calculations for our pulse in our mind, and then we just kind of hang out there, still pretending that we're counting their pulse, but actually we're looking at their breathing there and assessing that. Right, so we kind of got to be a little bit sneaky about it, right? Or maybe count it when the patient is talking to your partner, so they're not aware that you're, you know, weirdly staring at them or something. All right. All right. Skin tone, skin, not necessarily tone, skin. Skin's another vital sign that we're going to talk about. I'm going to keep an eye on the clock here. We'll go a little bit and then we'll go for another 10 minutes and then we'll take a 10-minute break at 10 there. All right. So skin, we're going to look at a few things. We're going to look at the color of the skin, the temperature of the skin, and the condition of the skin. Skin is so great. Like I always say it. It's like a billboard. It's this giant sign of. One second. Hi, my love, Sophia. Can you take your papers and your scissors into the TV room, please?
But I don't like the movie too scary.
Can you do it in your room then, please?
I will do it in my TV room.
Okay. Thank you. Do you need some extra paper?
Yes.
Yes? Okay.
Thank you.
There you go, babe.
Thank you.
All right. Get out of here, Munchkin. All right. Sorry about that. All right. So we're looking at color, temperature, and the condition of the skin here. And the skin is such a great billboard. You can't miss it. It's a big sign about what things, what could be going on in the patient. You can get an idea right away of if their cardiovascular system is working well, if the respiratory system is working well, just based on skin. So it's a great sign there. All right. So for color, this is obviously patient specific, right? It's based on that patient's skin tone, their color. And sometimes it's really easy to see that somebody is pale, or that they're healthy looking, or that they're cyanotic. Sometimes it's a little bit more difficult. We've talked about it. So if they happen to be more darkly complected, the color looks like it's washed out, that it's not as full or healthy looking, vibrant kind of. And you know, it's easier to see that on white people when they get paler there. If you're unsure, when you're looking at somebody's skin color to see if, they're pale or they're cyanotic, things like that. There's a couple places on the body that you can look for anybody. The nail beds um, are going to be basically pink for everybody. That's a good place to look. Inside of the cheek, inside of the mouth, there's a good place to look. And inside the lower eyelids. So you're just going to pull down their eyelid like that and see the pink part right in there, right there. Those are really good places to look on anybody. If you have any questions, those places, especially the eye and in the mouth, should be really pink. And if they're anything other than really pink, then we'll be able to tell. So why don't, when we take a break here in the next minute, if you guys can, maybe go to the restroom and check out in the mirror or in your phone, whatever, how pink the inside of your cheek is and how pink that is just underneath the inside of your lower eyelid right there, to get an idea of what's normal there. So everybody, regardless of color, those will be the same there. So we'll have some abnormal skin colors. Pale is one. And I don't mean like, there's a difference between somebody that's not been outside in the sun, right? Like I have a wonderful winter pale that my skin takes on during the winter time. I get nice and pale, but it doesn't look sickly. Right? There's a difference between like somebody that's, that works like night shifts and sleeps all day, and somebody, their pale skin versus somebody that's sick and their pale skin. So there is a difference. So abnormal will be pale. There's cyanotic. It's like a bluish, grayish color that we can see. Flushed is a red color that we'll see. And then jaundiced is yellow. They start looking yellowish there. That's usually an indication of liver issues there. All right, and then we're going to take a note of their skin temperature. What we want them to be is warm. We just want them to be warm. Easy way to do this is we can feel through the gloves. The gloves are thin enough where we can feel a patient's temperature, particularly if it's outside of normal. We can feel that it's warmer. We can feel that it's colder. If you have issues feeling that, you can peel off your glove and use like the back of your hand there a little bit. You can put it on there, or like against their wrist or something like that if you don't want to touch somebody's face. Now, one thing to note is that on the back of our hand, we have less nerve endings here. So if you're having a hard time kind of figuring it out, use the front. We have more nerve endings on the front of your hand. Obviously, I'm not going to touch a patient with my bare hand. I don't want to do that. But I can roll up my glove enough where I can give them my wrist. This still has more nerve endings than in the back, right? You can actually tell when you do this, it feels more sensitive than back here. It's because we have more nerve endings over here, okay? So you can do it for either side. If you're having difficulty telling with the back of your hand, then do the anterior portion of your wrist over here, okay? So you don't have to actually touch the patient with your bare hand. It'll just be your wrist if you need to, but usually feeling through the gloves is pretty good. We just want to note if the skin feels normal, which would be warm, if it's hot, cool, or even cold there. So there's our extremely, I don't know, that guy looks pretty sedated, doesn't he? Looks pretty sedated. I don't know. That just makes me laugh. All right. Pediatric note for kids under 6, we're going to do capillary refill. I think we talked about this in class before, but if we did not, what it is you're going to get a fingernail. Hopefully it's not painted. You can go ahead and do this now. So take your thumb and press down on it. You're going to see all that pink go away underneath your nail bed. It's going to look white there. And what you're doing is that pressure that you're putting down there, it's pushing all the blood out of the capillaries that are right underneath there. So the skin that's right underneath your nail, you're actually pushing the blood out of those capillaries, right? Like when so that's what's happening there. And so what you want to do is you're going to press down until it's white and then let it go. And what you're going to see, when you do that, you're going to see that pink refill in there, right? That's literally the blood refilling the capillaries when you do that. A normal finding is that it becomes pink again in less than 2 seconds, or basically by the time you say capillary refill, it should be refilled at that point. So less than 2 seconds is the standard that we'll use, but generally you can do it and be like, capillary refill. Oh yeah, it's filled up. All right, this is good for kids 6 and under. Generally, we don't use it on adults because maybe they have medical issues that prevent that from happening well, right? But kids, generally, that's a good thing to use for kids. All right, so cap refill. Good for kids, generally not good for adults. All right, let me check the time here. We'll do pupils and then we'll take a break, okay? All right, so we know the pupils are, we did this in class. The pupils are that black part in the center of the eye. The iris, which is the colored part, changes its diameter, basically, and so our pupils either constrict or dilate. When it's a dim environment, it's going to be larger, the pupil, to let more light in. When it's a bright environment, the pupil will be smaller and more constricted to let less light in. So like what we're seeing isn't washed out with too much light, right? So when assessing this, we want to note the baseline size of it. So before we do anything, just look at your patient's eyes. Are they big? Are they small? Do they look to be a normal size? That can be a finding. There is like when somebody is on opiates, right? Narcotics or any kind of narcotic there, they have pinpoint pupils. They're tiny, 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 which is easy to see. It looks weird. Their eyes are just full of color. There's almost like no pupil there. It looks like the end of a pencil or something. It's very, very small. Looks like it does look like the tip of like a lead pencil there. We can cover one eye and shine the light into the other eye and then reverse it. The reason we want to do that, especially in bright environments, is that shining the light into one eye it'll affect the other eye too. So we want the reading when we do it for the other eye just to be solely that. If we're in a dim environment, if you turn the lights down in the back of the ambulance and it's like nighttime or evening, then you're generally going to be fine there. Just do one and then wait a second and then do the other. I would suggest practicing a little bit. You can do this at home in the mirror with yourself and, just kind of look in the mirror at yourself and just kind of use a little flashlight or maybe your cell phone flashlight to bring it over and kind of shine it into your eyes. You may have to take your glasses off if you do it. Hopefully you can see to the mirror when you're doing that. What we have to get used to is the speed at which they change. And we also have to get used to what the normal size is, so that when we do encounter a pupil that is of abnormal size, we can tell. So here's our guy getting his things, his pupils checked there. All right, so assessing them, what we're going to look for is size, equality, and reactivity there. And what we say is that the pupils, if it's normal, the pupils are PEARL. It's an acronym, and it means pupils are equal and reactive to light. PEARL. Pupils are equal and reactive to light. That's the good thing. That's what we want. There can be different types, okay, different findings. So They could be very constricted, like this picture at the top. That would be like a narcotics user. If we're in like regular light and it's, you know, pinpoint, we're in a dark environment and it's still pinpoint, that's narcotics, right? Um, Dilated pupils, they can be other drugs like barbiturates, things like that. Unequal pupils is a serious finding. That means there's probably been a head injury. So people who have strokes, people who have had traumatic head injuries, they can have unequal pupils like this. I meant to do this the other day. So this is a picture because I had a doctor's appointment for my eyes a couple weeks ago, and I meant to do this, but she was too quick, and I forgot to ask in time. So this guy has had, if you have glasses, you've had this done. This guy has had his left pupil dilated. So when you go to the doctor's office and they check your eyes, if you don't know, if you're one of the lucky people that doesn't have glasses, they'll put a drop of medicine in your eye and it dilates your pupil, makes it really big. And I meant to have the lady, I meant to ask, but as she was putting the second one in my eye, you know, I forgot, but I was going to take a picture of myself. But this guy has it, right? So you can see this is unequal pupils. His right pupil is normal, right? It's the smaller one. That's the normal one. The other one is dilated, right? Medication did this to this particular gentleman. However, if we have a head injury, a stroke, something like that, that's what you're going to see. All right, you're going to see that can be a finding of a head injury, some type of head injury. So we'll get that there. All right, so try to practice that, like in the mirrors and stuff at home when you do that kind of thing. Also, what I would like you to do is start paying attention to people on TV. All right. There are lots of people on TV nowadays that you can tell are on something, whatever it is, you know, who knows, but their pupils are not regular. They are not regular. They're either very dilated in a very bright environment, you know, like press conferences or, you know, things like that, or they're very, very tiny. And so it's out there. Um, you can watch various news channels and see it. You can see it on TV shows and things like that. So most people don't know, but it's a little secret. And, you know, like, I know your secret. I know you're on something, you know, when you see somebody like that. So the other day I asked you to start paying attention to people's skin condition and get a general impression of them. So when you're talking to somebody, if you guys work, things like that, and you're dealing with customers, check out the pupils, right? Check out the pupils. See if you can find anything like what's normal, like if you're at work, you know, for the lighting in that environment, and then try to find somebody that's abnormal, right? They're too dilated or too constricted, right? Because they're out there. I promise you, they're out there. All right, let's take a break. We'll pick up with blood pressure right now on my phone. I have 10:05. So we'll come back at 10:15 and we'll finish up. How's everybody here? Are we good? Do we have any questions? Dylan, good. Anybody else got any questions or anything? Oh, Sophie, I just saw your encouragement for, I guess, killing the spider. Thank you very much. Haley, good. All right. All right, we'll come back in 10 minutes at 10:15 and we'll go from there. All right.
The mic's muted. Your mic is muted.
All right, everybody back. Ready to get rolling again. All right, cool. Cool. All right, let's get rolling here. So, all right, cool. Got some thumbs up for me, folks. Excellent, excellent, excellent. All right, let's talk about blood pressure. So we started learning about these, in increments. We learned about what the systolic was and diastolic and how to take it. And uh, moving forward, especially now that because of these couple of weeks, basically it is going to be your standard for our cup of Joe, right? We're going to have to um, start making it a point to take at least a couple of blood pressures a day just to start practicing there. We know that's the force of blood against the walls of the blood vessels, the arteries. Um, Normal is the systolic isn't greater than 120. Right? Normal is right around 120 there. Diastolic is right around 80. Okay, so for example, myself, I'm usually like 114 or 116 over like 76 or 78. And that's normal. That's normal. It's not those numbers, but it's right around there. And that's considered normal there. Changes can indicate something very significant. Obviously, this is a sign about our cardiovascular system and how it's working, how well it's working. So if we have a very low heart rate, our blood pressure is probably going to be very low too, or eventually it'll be low. Shock, one of the signs of shock when we're looking at vital signs is we have a high heart rate, high respiratory rate, and a dropping blood pressure. So we'll have to get trends, take it multiple times, and we can see the blood pressure drop there. So it's measured with a sphygmomanometer and a stethoscope. The sphygmomanometer is the BP cuff. It's the blood pressure cuff. Say that one 10 times fast. Right? Sphygmomanometer. It's always a fun one when you're learning this new medical terminology, trying to figure out how to say that. So we do it with those two things. We know where we should put the cuff. It should be the upper 2/3 of the arm, from elbow to shoulder there. And we need enough room at the crease of the elbow right here to place the bell of the stethoscope, so we can listen to that artery right there, the brachial artery that goes, there we go, goes up between, right in the middle here. So we need space here for the bell of the stethoscope. All right, so that the bottom of the BP cuff, it can't be down into the crease of the elbow. It's got to be above it by like an inch or so. So we have enough room there. Here we can see the dial, the gauge there. We can hook it onto the BP cuff. It's got that little clip. You can put it on a patient's shirt. You can always have the patient hold it if they're conscious or willing to, and things like that, to wherever you get to need to see it. All right, there is a on the cuff itself, it says artery, and then there's an arrow. We want to make sure that that's over the brachial artery. If it's off too much, it can affect the reading. So we want to make sure when we line it up and put it on, we have that little arrow where it says artery, right over our brachial artery there. All right, so determining blood pressure by auscultation. If you guys remember, auscultation means listening. Okay, this is the normal way we take blood pressure, by listening with the stethoscope. So just go through the steps. We got to get the patient ready, and that means that basically have them sitting down, have them stop moving around, and then the arm has to be relaxed. if they're holding their arm up, that's going to affect the blood pressure. It's going to actually raise the blood pressure up. So just make sure the arm is relaxed. It's nice and relaxed. So have it laying on a table, laying on their lap. You can even put it on your lap in the back of the ambulance. You know, there's not a lot of room back there, and you can just put their arm basically on your lap to rest it there. We position the cuff in the stethoscope. You can palpate the brachial artery right here. You can feel it a little bit. And you can put your stethoscope right there, okay? Right where that artery crosses, right in between the radius and the ulna, where it's kind of diving down in between them, going through around over top of the elbow, in front of the elbow, and then down into those, in between those two bones there. So we're going to place the position there. And we're going to put that bell end of the stethoscope right over top of that. We're going to inflate the cuff. Okay. Now, again, I was really clear about this, or I tried to be anyway, when we started learning this. When we're pumping it up, you can pump it up really slowly. Okay. Systolic on somebody that is conscious, they're alert and oriented and that kind of thing, you can almost always guarantee that it's going to be above 90. Okay. That they're systolic, the high number is always going to be above 90. So you can pump it up quickly to 90, but once you get to 90, kind of pump it up a little bit slowly. All right, because we want to be able to hear that pulse. It's going to start coming in once it starts, the cuff starts tightening around the arm. We're going to be able to start hearing that pulse. Okay, and what we're listening for is once we hear the pulse, what we're listening for is for it to disappear. All right. Once it disappears, then we're going to add 30 points. We're going to give it another squeeze or two and add 30 points on the gauge. All right. We do this so that when we release the valve, because you guys saw it, sometimes it's sticky and maybe it releases too fast because it's stuck a little bit and you turned it too much and it deflated too quickly. Giving us 30 points above where that sound disappears allows us to kind of adjust that valve a little bit so we get a nice, smooth, slow drop of that needle. Okay. The reason I was really specific about that and why this is important is because you'll find people, nurses, doctors, EMTs, paramedics, you know, whoever takes blood pressures, you'll find the people that are cutting corners. And the people that cut corners generally just jack that cuff all the way up to like 200, right? And that hurts. That hurts. So if you're doing something, and I have a problem with it because I think if you are doing something and you are going to intentionally cause pain for somebody because you're too lazy to do it right, like there's a big problem. I think that's a fundamental problem with that caregiver, frankly, because this isn't that hard. It's tough to learn, yes, and to start getting it right. However, once you get it, it's like riding a bike. You'll always have it. But you know, like I said, I just have a fundamental problem with somebody saying like, yeah, I don't care if it hurts you. I'm just going to be lazy and pump it all the way up. I think that's lazy. And there's something fundamentally wrong with the reasons maybe that they're there. Maybe they're burnt out or something. I don't know. So listen for it to disappear and then just add 30 to it, right? We don't need to unnecessarily put people in pain in doing that. So once we get it 30 above, we'll turn the valve there, slowly release that air, and we'll make sure that needle's coming down nice and smooth, nice and slow there. We don't want it going too fast, and we don't want it going too slow either. There's a nice middle ground in there somewhere, and you're just gonna have to, the more you do it, the more you'll get used to what that middle ground is and what's a nice, slow movement for that needle going down. When you hear the first heartbeat, that's your systolic number for first heartbeat. One thing to note about that needle going down, we've all seen it. It kind of bounces a little bit. Those bounces, people will get confused and say, well, I saw it bounce at the first part where it bounced, and they'll assume that's a systolic, but that's not the case. That's not the case. What you'll see is it'll bounce before you can hear the systolic. And so if you take where it bounced the first time, you're artificially inflating their blood pressure. So the only thing you can say about a bounce and meaning anything is that it will bounce, probably, most likely, it will bounce before your systolic. So if you see a bounce, then maybe it's like, all right, I need to start listening real close right now. But we're never taking that bounce into account really for anything. The only thing that it can tell us really is, the systolic is close by. That's it. But we should know about where we're going to hear the systolic, because we heard it disappear somewhere as we were inflating it. So let's say it was right around 120 that we heard it disappear, put 30 more in, it goes up to 150. And as we're listening, I'm looking at the gauge. It's like, all right, here comes 120. This is where it disappeared. I should be listening real closely here. And then hopefully you'll hear it right around there. So we get an idea of where the systolic is when we're inflating the cuff, and then we'll pinpoint that when we're deflating the cuff. The diastolic pressure, right? When we first hear that heartbeat come in, it's gonna continue for a little bit. Bump, 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 and then it disappears. So that first heartbeat where it's gone, the first heartbeat that's missing when we're listening, that's your diastolic pressure, right? So we should be able to figure out the rhythm and predict when that next heartbeat is going to land, right? And then and the first one that's missing, that's the diastolic pressure. And then we're going to record them. It's written over as 120 over something, or over a number, right? Like a fraction, basically. So record that number. And then there's a way to record blood pressure just by palpation. And that palpation, if we remember, means touching, right? Feeling. And the reason we'll do this is because maybe their heartbeat is so weak, it's really difficult to hear the pulse. Or maybe the environment is too loud. Maybe there's 3 EMTs in the back of the ambulance and they're all talking to each other about what needs to be done, and packages are being opened and there's beeping sounds from the monitor or whatever it might be, right? The sirens are going as you're headed to the hospital. You're bumping down the road, maybe the road's bad, right? All these things contribute to a noisy environment. So we may not be able to hear it clearly. So doing it by palpation is you're going to put the cuff on, and then we're going to find the pulse, right? On the radial pulse. We're going to inflate the cuff, and then same kind of thing, right? Remember we were listening for the sound to go away? Well, in this one, palpation, we're going to be feeling for the pulse. We'll inflate the cuff, and we're feeling for when the pulse goes away. Right? When that pulse goes away, we can't feel it anymore. That's right around your systolic number. So give it another 30, let it go down, and then you're still feeling here, right? So you pump it up, you let it go down, you're still feeling. And then when you feel the pulse, the first heartbeat that you feel, that's your systolic number. Now, if you notice, I don't have a blood pressure cuff on. Nobody's taking my blood pressure. So I can feel my pulse. So you're like, well, how do you get the diastolic number if you're doing it this way? You don't. So when you're doing it just by palpation, you're only getting the systolic number. And a lot of times that'll be good enough. It is an incomplete picture. There are certain injuries and things like head injuries in particular where we do want to get that diastolic, but for most things, it'll be okay that we don't have it. So how do we note this? If we get a blood pressure by palpation, we'll say it as 120 over P or 120 over palpation, something like that. Okay. 120 over P is normally what we'll say, whatever their systolic number is over P there. Kids, when they're really small, it's hard to do it. It's hard to get it done. There are pediatric cuffs that are real small for them, but sometimes it's difficult to do it. We can look at other things though to get an idea of how their cardiovascular system is working. So we can look at their skin condition. Are their respiratory work? Are they breathing well? Are they working hard? Do they look cyanotic or pale? We can do capillary refill on kids. That gives us a good idea about things. So if you're not able to obtain it on a kiddo, which is not unusual, then let's look for these other signs, right? What's their skin look like? What's their work of breathing look like? And if those things are off, then you can probably think in your head that, all right, then the blood pressure is going to be off for this. One more pediatric note. As you'll see in the chapter, it's going to give us tables about where normal is for age groups. Pediatric vital signs are different. So heart rate and respiratory rates will always be higher than in adults, but blood pressures will always be lower than in adults. So it's not unusual to find let's say a 4-year-old would be 98. Okay, that's around the rule for a 4-year-old. I'll explain to you how we get that in a second, but their systolic would be like 98 for a 4-year-old. That is generally where we would find it, around there. So context matters again. So if it's a kiddo, expect heart rates and respiratory rates to be higher, but blood pressures to be lower. All right. As they age, blood pressure comes up and heart rate, respiratory rate comes down to where they're at about now for all of us. All right, getting the blood pressure by a blood pressure monitor, that's really simple. And, if you're in the back of the ambulance, that's usually how it's done nowadays. So we put the cuff on the patient, and all you got to do is hit BP on the monitor, and the monitor starts doing it itself. Now, if the monitor takes the blood pressure, we can have odd numbers. All right. If we do it manually, the numbers are always be even. Okay. For all of our vital signs, if we do it manually, all of our vital signs will be even numbers. Respiratory rate, heart rate, blood pressure, right? Those will all be even numbers. But if machines are doing it, we can get odd numbers, and that's okay. All right. Temperature. All right. Temperature is pretty simple. We just want to kind of feel the skin, and we want to note the changes there if there's any. Our cells make the process of them making energy and doing their little jobs creates heat. It's one of the byproducts of it, and that's how we stay warm, and that's what gives us our body temperature. The temperature of the patient reflects what's going on in the body. So if the body's working extra hard because, say, for example, it has a virus, the temperature is going to go up, and that produces a fever because your body's working harder there. If, for example, you're out in the cold, what happens is the cold will slow down your body's processes. So your cells aren't making as much energy. They're not doing as much of their jobs. And so the heat that they make is reduced. So your body temperature gets reduced as well. Normal temperature depends on a couple of things. Activity level. If your patient was just very highly active, their temperature is going to be up, right? Your cells were doing more activities, converting things into energy and stuff. And so the heat that is generated goes up. things like that, age, all that, where it's measured. Like for example, where it's measured matters. I don't know. Maybe she's an anomaly. I don't know. But my kid, when she has a fever, her head, you always check, you put your hand on their head, you feel how they're feeling there, or you put the temporal thermometer on or the forehead scan, right? My kiddo, her temperatures are always lower on her head, always, versus her body, always. I remember last school year, she got really sick, and around like January or something, she got real sick, and she had a real high temperature. I took it on her head, and it was like 100 point something. But then I took it on her body, and it was 100 and I think it was almost 102 or something. So there's like 2 degrees difference, which is large for a temperature. So where it measured matters as well. Um, so it can feel different. Right, I know it's weird. Dylan just gave us the surprise look. So um, a way to judge that is just by touching. You know, so when I take her temperature, first place I'll feel is always her head, but then I'm always going to put a hand on her chest and her belly, because those are always hotter for her when she's got a temperature. So that might be a good thing to do for patients. Like touch their head. If you feel a little bit warm, maybe touch the skin like on their chest, or neck, around this area, or on their belly, something like that. That'll give you a good idea. All right. So generally, though, most ambulances don't carry thermometers. To be honest with you, I think I've seen one in once. So what we're doing really is when we're checking the skin condition, we'll check that, whether they're warm, cool, or cold. But generally, you're not going to have a thermometer on the ambulance. All right. Oxygen saturation using the pulse ox. It measures the amount of oxygen that's on the hemoglobin. Remember, hemoglobin is the part of the red blood cell that actually carries the oxygen. So it's measuring how much oxygen is attached to that. We measure it with the pulse oximeter, obviously. When to use a pulse oximeter? On every patient, just put them on it. That's how you're going to take their pulse anyway, most likely, when you're getting your vital signs, because it's fast and it's easy to do. Sometimes there are protocols for using it, different places, but we especially want to use it for any patients that are at risk for hypoxia, right? Because this is going to give us some good information about our oxygen treatments. So anybody that's at risk for hypoxia, so any respiratory distress, any respiratory failure patients, obviously respiratory arrest, cardiac patients as well, somebody presenting with like a chest pain problem, stroke patients are also good to use that on, because we have to know how much oxygen we can give heart attack and stroke patients. We can't give them too much because it can actually make their conditions worse. So generally, you're going to use it on every patient. They're readily available. They're easy to use. You turn them on, you put them on a finger, right? So it's not difficult. And here's a picture of one. We got heart rate there and the SpO2. The SpO2, that is the percentage of oxygen that's in the blood there. And so normal is 96 to 100. There, we know that. 96 to 100 is normal. And that mild hypoxia is 91 to 95. Significant or moderate hypoxia is 86 to 90. And then severe hypoxia is 85 and below. 85 and below. Generally, mild hypoxia, we can probably take care of, at least until we get to the hospital, with a little bit of oxygen. And our goal, I'm going to give you a handout about giving oxygen, what Virginia wants us to do when we're giving oxygen. So generally mild hypoxia, we're only giving a little bit. And our goal whenever we're giving oxygen is to get somebody to 94% or above. I know 94 is mild hypoxia and you're like, what's the deal? But it's just right there. It's right there. We should have a normal mental status at 94% there. We should probably have a normal mental status probably down to 90 or so. That's fine. After that, we're going to start to get mental status changes, most likely. It can be earlier though, depending on the person. So any oxygen treatment that we give, we want to get them to 94%. So if we're at 92, maybe we only need a little bit. Nasal cannula, maybe at like 2 or 4 liters per minute. Anything below 90, we're probably going to be using the non-rebreather there at 12 to 15 liters to get them up to the 94%. All right, so, this looks like it's pretty easy to interpret, doesn't it? 98% oxygen levels and 82 heart rate. Well, we can have conditions that cause us to get bad readings. So it's important to know about that. Shock. All right. If somebody's in shock, is the body still letting blood get out to here, or is it taking the blood from the skin and out in your arms and legs and hands? Is it taking that blood and shunting it towards more vital organs? Right. That's what it's doing, right? The brain needs the blood if they're in shock. The heart, the lungs, the kidneys need the blood there. So it's not going to be out here. So we're not going to get a good reading if somebody's in shock because there's not enough blood out here, right? Same thing with hypothermia. When somebody's been out in the cold, well, to keep our core temperature up, our body is going to shunt blood away from our extremities, from our hands and our legs and our feet and our arms, right? So there's not really going to be a lot of blood out here to measure. So that can throw off our readings there. So we got to know that shock and hypothermia can change those readings. Carbon monoxide. Carbon monoxide is a invisible gas. It's odorless. It's colorless. You can't tell that it's there, but it can throw off the readings. What's crazy about carbon monoxide is that it is 200 times more likely to bond to hemoglobin, to attach to hemoglobin. It's 200 times more likely to attach onto that than oxygen is. So if somebody starts breathing in a lot of carbon monoxide, well, all that carbon monoxide starts taking up all the places on the red blood cells. And so oxygen can't fit on there. But so your person is going to be saying they're struggling to breathe and all that kind of stuff, right? They're going to feel short of breath and everything. But when the pulse oximeter reads it, it just sees that the hemoglobin is full. And so it can give you what looks like to be a normal reading. Maybe it shows them at 98, 99%. But in reality, what's happening is it's just reading the carbon monoxide on there. The pulse oximeter can't tell the difference between oxygen and carbon monoxide. And again, carbon monoxide is going to take up all the spots on the red blood cell, and oxygen won't be able to fit on there. And so that'll give us a false reading. It could show a totally normal reading when in fact there's very little oxygen in on those red blood cells. So that's a little bit, crazy there. So just to note that. Other types of poisonings can do it. Excessive movement, if they're waving if they're a talker, they talk with their hands a lot, right? Just have them sit still and relax for a minute or something. Nail polish can do it. So the little laser that's in it should be shining down through the nail, but can reverse it and put it on the other side. That can work in a lot of cases too. And anemia can throw it off too. So if somebody's anemic, they don't have enough red blood cells, then it's gonna throw off the reading as well. Excuse me. All right, blood glucose meters. We'll learn about this now, but we're gonna do it when we get to our diabetic chapter. It measures the amount of glucose in the bloodstream, how much sugar is in the bloodstream, and it can help identify where we are with diabetic emergencies. One of the common things with being hypoglycemic, having low blood sugar, one of the first things is an altered mental status. So for people that are unconscious, or if they have an altered mental status, or if they're a known diabetic, we're checking this. If somebody's mentating well, they're not a diabetic, that kind of thing, we don't need to get this. We're not going to need to get this. But if they're altered mental status, if they're known diabetic, if they're unconscious, we're definitely getting this, because this could be a reason for all of those things. And it's a simple fix. We just give them some sugar, right? And give them some glucose there. So we'll use these. This is what they look like. Let me see if I got my thing here. 1 second. Spotlight. All right. So I don't know if you can see this. Hopefully you can see the spotlight here. So these things on the right-hand side, you pull the little blue thing out at the end, and then that blue button on the other end, you just put this against their finger, you press it in there, and it shoots a little needle out. Just it jabs them real quick, and we get a drop of blood. We do this on their finger. There's some test strips we dip into the blood, and we insert into the monitor there, and it gives us a reading there. Some places don't allow EMTs to do this, but we can use them. It's got a test strip, a device, the lancets. We're going to prick the finger with the lancet, get the blood in the test strip, insert it into the monitor, and then it's going to give us a reading. Again, I'm not going to spend too much time on this right now. Know why it's important and know who we do it for. But when we get to the diabetic chapter, that's when we'll start, and we'll do that soon, in a couple of weeks. That's when we'll actually do the activity to learn the blood glucometer. All right, normal for blood glucose is going to be basically between 60 and 140 there. So it's usually at least 60 to 80. Probably right now, like around 100, it can be normal. This is confusing, and this is what the book has said and stuff like that. But basically, we want to be above 60. At 59, we're starting treatment. Okay, at 59. So usually somebody's around 100. Now, what can happen though is after you eat and your body hasn't put all that sugar into your cells yet, your blood glucose reading is going to be very high. So you may be around 200 or so after you've eaten a meal, and that's normal because your body just hasn't taken the glucose that's now in your bloodstream and put it into your cells. Eventually that number is going to drop to something, more normal, or around 100 or so. So 59 is where we're starting treatment for low blood sugar, though. That's an important number to remember. Let's go back to this real quick. There's some important factors to determining the number that we got to keep in mind. If somebody's just exercised, they've burned off a lot of blood sugar, so it may be a little bit lower. If somebody hasn't eaten for a long time, they don't have very much. They may not have very much glucose in their bloodstream because they haven't taken any in. If somebody's sick and has a fever, their blood glucose levels could be down as well. If their body doesn't use insulin or produce insulin well, all right, if they're diabetic, they've taken too much insulin, I should say. Maybe that causes the number to go down. Lots of vomiting, if they've just eaten and they vomit everything up, that can cause the numbers to go down. So lots of things can cause those numbers to fluctuate, right? So like common problems for diabetics is taking insulin and then not eating afterwards. Or they didn't eat maybe in the morning and then they went and exercised, right? And so they burned off all their sugar and they don't have any to put into their cells, right? All right, pediatric notes, normal range for kids with their vital signs, again, faster pulse rate, faster respiratory rate, and lower blood pressures than adults there. All right, let's talk real quick about the pediatric note, how to figure it out. This just changed there, so let me, what time is it? Do I have enough time to do this? 10:52. All right, I want you guys to write this down if you can. I should have this up. It should be on this slide here, but it's not. Figuring out a figuring out a kid's blood pressure if they're under 6 or so. What you're going to do is here, let me share my screen here again. Oh, I got a whiteboard. I should do that. It doesn't matter. All right, figuring out a kid's blood pressure. Let me just do this. You can, hopefully you can see this. All right, it's 90 times 2 times the age. All right, that's a kid's blood pressure there. All right, so for like a 4-year-old, right? Let's do that. Let's do like a 4-year-old. So we're gonna go 90. Excuse me. Not 90 times. Not 90 times. I'm insane. That'd be crazy. 90 plus 2 times their age. Okay, so 90 plus. We're gonna do 4-year-old. So 90 plus 2 times 4, right? Look at me doing math, writing equations. All right, 2 times 4 is 8. 90 plus 8. A 4-year-old's blood pressure should be 98. Their systolic number should be 98. Okay, that's how we figure that out. Real simple. It used to be 80, but they just changed it this last year to 90. You'll notice in the chapter when you read it. All right, so PEDS BP, it's 90 plus 2 times their age. Okay. So 90 plus, if this was the age, 4-year-old, then it's 98 would be their blood pressure of where it, and that's not going to be their exact blood pressure. It's going to be where, right around where you should find it, right? We say 120 is normal, but it's actually right around where we should find it. Like mine's 114, 116, that's normal because it's around 120. So when we're figuring out kids' BP, it's not 98 exactly for a 4-year-old. It should be right around there. All right. Okay. All right. That's it for today, folks. Don't forget the homework and quiz Monday by 11:59 p.m. And then this chapter, the reading for it, we're just going to have a short quiz on it. That will be open resource. So when you get the chapter 12 stuff done, read chapter 13. It's not very long. And then we'll have a quiz. That is going to be due by Wednesday of next week. Okay. Because we're just plowing through this stuff like we talked about before. So Wednesday of next week, I will have it out to you today, tonight, this evening. I'll have that out for you guys, and so just have that done by Wednesday. All right. So chapter 12 stuff due Monday at midnight, and chapter 13 stuff will be due Wednesday at midnight. Okay, guys, have a great weekend. Be safe. Have fun. Don't forget, look at people for your primary assessment. Right. See if you can find out, look at somebody's skin condition and things like that. See if you can form a general impression. And if you do, like, why do they look good or why do they look bad? Start looking at people's pupils, right? I know I don't know if anybody in this class does, but I know that we have a bunch of like cashiers, throughout the classes and stuff. So you get to see people's pupils even behind their masks. So look at the pupils to see if they're normal. See if you can spot people like that are on something. Maybe it's like a narcotic and they have pinpoint pupils, or Maybe it's something else and they have really dilated pupils, something like that, right? So start looking at people, start assessing them. Be safe, have fun this weekend, and we will see you next week. See you guys.